Good afternoon, everyone. Welcome once again to our webinar. It's exactly 3 o'clock now, so I will be handing over to Dr. Abiola Fasina. She'll be taking us through this session. Thank you so much for joining in once again. I would leave Dr. Abiola to give a brief introduction of herself before she takes on the presentation. Thank you so much for joining us, Dr. Abiola Fasina. You're currently muted.
Thank you, Peace, for the great introduction. Can you hear me?
Yes, we can hear you now.
All right. And thanks to everybody who's joined us as we're going to be talking about the management of common emergency conditions. A brief background of myself. I'm an emergency physician. I completed my MD and my residency in emergency medicine.
Hello, Dr. Fasina. I don't know if you can hear me.
I can hear you.
Okay. The Teams interface is showing on your screen.
Yes. Do you want me to turn it off?
Yeah, so that they can see the slide.
Okay. Sorry. So that's all right. So yes, I completed my MD and my residency in emergency medicine at Mount Sinai School of Medicine in New York. And I worked for several years as a consultant emergency physician before completing a fellowship in point of care ultrasound and also a master's in health policy research at the University of Pennsylvania. I moved back to Nigeria 3 years ago, and I've been working in emergency medicine since, developing the specialty. I'm very active at the National Postgraduate Medical College as a foundational fellow and a faculty board member of our first board. And we're very proud to say that emergency medicine is now a recognized specialty in the country, and we're rapidly scaling up on accreditation of training sites so that Nigeria will soon produce an emergency physician. For the last 2.5 years, I've been functioning as medical director at R-Jolad Hospital and also the director of emergency critical care services. We launched our emergency department there about 1.5 years ago. And so I'm very happy to take us through this talk discussing the management of common emergency problems. And I'll take questions at the end of the discussion. So a brief history of emergency medicine. We're quite young to the House of Medicine in general. It started in the United States in the 70s. The first training program was actually at the University of Cincinnati in 1970. I talk about the old days of emergency medicine because it's really what we find in any place where emergency medicine is starting anew. The modern development of the specialty began in the 1960s when there was a need for specialized care for acutely ill or injured patients. So you can imagine what things used to look like in the past. There was a room designated somewhere as an emergency. All comers would be there. And there was really nobody that was in charge or anybody who was focused on actually taking care of the patients in a holistic way. And so what used to happen is that the different specialists in the hospital would come to the emergency med department and pick the patients that were relevant to their practice and manage them and sort of leave them. So there was also no continuity of care, and there was no way to actually ensure that people were managed appropriately. So there was no standardized emergency care, and it led to fragmented and often inadequate care and a lot of bounce backs to the emergency department. Now things have changed. Usually now there are designated spaces for emergency care that are staffed by trained specialists in developed countries and also actually in some of the other countries of Africa. South Africa is very far ahead when it comes to emergency development, of course. And Ghana is about 10 to 12 years ahead of Nigeria in terms of what they've been doing to really build an emergency care safety net. Now we have a coordinating specialist trained in the acute management of a wide spectrum of diseases, including critical care, to perform initial stabilization. And our specialization is actually resuscitation. That's really what we do best. We're really there for you at the end of life to ensure that we give you the best chance of surviving in order for you to then go on to definitive management. And so that's what emergency care is really about. What's going on with emergency medicine in Nigeria? Well, prior to the establishment of emergency medicine as a specialty, again, we've talked about this, how various health professionals, including general practitioners, surgeons, and nurses, were providing emergency care. And that's still the case in our country because it's still a very new specialty. The World Health Organization has made strengthening of emergency care systems a key priority. And there was a resolution passed about a year and a half ago recognizing that it would be impossible to attain universal health care without considering the impact of emergency, operative, and critical care services as a foundation of a health safety net. Rightly so, we've always focused on public health and primary health care, mother-child diseases, communicable diseases, and those things still kill quite a number of Nigerians. But I think it's important to begin to recognize that we also need to strengthen the care we provide during acute illness, which is a place where we've traditionally fallen short in this country. So over the years, EM has evolved to become a vital component of the healthcare system in the United States and actually very much in the whole world. It's recognized now as a specialty that requires specific training and expertise to provide comprehensive and timely care. And we provide a very crucial role in the development of emergency care in hospitals, emergency departments, and pre-hospital settings. We're growing out of the emergency department now. Many EM doctors are now going into the C-suite as CEOs and hospital directors because the emergency department is a crucible and it is the front line. And we are usually the bellwether of the system. Things pop up in the ER long before they pop up elsewhere in the system. And we're very quickly are going before they become apparent. A good case or example of this is during the pandemic of COVID, where we actually began to see very strange presentations of respiratory illness in US emergency departments before it was officially recognized that a new virus was around. As I said, emergency medicine was recognized as a specialty in Nigeria in 2019 by the National Postgraduate Medical College. Currently, we have 30 foundational fellows, 10 of whom are actually emergency physicians, 20 were co-opted from other specialties. And currently, unfortunately, Nigeria only has 4 residency trained emergency physicians. There are many people working in emergency departments in the country. There are only 4 who've actually been trained as specialists. And that's an alarming statistic. It means that when you go into an emergency department in this country today, it's probably likely that the person treating you has received no formal training in emergency care. The first training program in EM was launched at UCH Ibadan in 2021. Run by my friends, my really good friends, Dr. Dufini and Dr. Akiola, and they're doing a fantastic job. Everybody is eagerly awaiting the graduation of their first class. So let's talk a little bit about our emergency department in R-Jolad. We launched it in March of 2022. We see currently an average of 330 patients every month, and we're capable of stabilizing all comers along the entire spectrum of care, from pediatrics to geriatrics. It's a small 3-bed unit, but I say we're small and mighty. Each bed is resuscitation capable and able to deliver care for the initial stages of critical care. We have standard resuscitation equipment for a modern emergency department. We have a great point of care ultrasound system. We have multi-parameter monitors at every bed, including invasive monitoring with CVP and arterial lines. We have a ventilator for non-invasive and invasive assistance. We have our crash cart and our modular defibrillator. We have equipment for airway stabilization, and I'm very capable of managing airways. It's a core part of our specialty as EPs. And of course, I'm at the helm managing the department. And there are very few EM departments now in Lagos that can actually say that there's a specialist managing care. Our biggest limitation, which is what I'm hoping we'll address today in this talk, is late presentations. For a variety of social, demographic, and economic factors, Nigerians tend to present quite late to the emergency department. And it really sets us back and provides a challenge when we're trying to provide good care, because a lot of the things that we're doing in emergencies are time bound. And we have patients presenting sometimes 24, 48, 72, or even weeks after the initial symptoms started. And now we are trying to rescue them when things are quite late. What are some of the common emergencies we're seeing at R-Jolad? We're seeing a lot of hypertensive emergencies, including urgency and emergency, and also strokes. We're seeing quite a bit of trauma. We're very close to some very major highways, and I've had some pretty hairy trauma cases coming. We see quite a bit of sepsis and septic shock from infections, including tropical infections. a lot of pediatric infections, including malaria, upper respiratory infections, and acute gastroenteritis. Most of the surgical emergencies are seen often with us: bowel obstruction, appendicitis, cholecystitis, and we see quite a number of seizures. This list isn't exhaustive, but I would say that these are the things that we see a lot of in the department. So I wanted to go through some of those common things and just give people a sense of what to look out for. What we're hoping to do with this talk is to sensitize people to recognizing emergencies and also facilitating early transfer to emergencies as soon as possible. So stroke symptoms. You don't have to be a genius to see these actually, and that's the point. They're easy to read. Any facial drooping where you're noticing that the face seems skewed or the smile is uneven, any body weakness of the arms or legs. Sometimes it's hard to understand if somebody has body weakness, but if grandma was walking before and all of a sudden she wakes up in the morning and is limping and tells you she can't move her leg, I would consider that to be body weakness. This feeling of being off balance. Sometimes patients who have strokes can tell you that they're feeling like the room is spinning or that they are moving oddly through space. People who have trouble speaking, they may have slurred speech, or they may have trouble understanding what you're saying. Occasionally, we also have patients who actually seem to understand but are speaking gibberish. So trouble speaking can also span a spectrum. And then vision problems, people telling you that they have parts of their visual field obscured, or parts of it have gone black, or that they can't see through certain parts of their eyes. And so when you're hearing these things, especially in the right kind of patient, we ought to consider a stroke as one of the reasons why this might be happening. Talking through a little bit about stroke in Africa and the risk factors. So stroke is a leading cause of disability, dementia, and death worldwide. Approximately 70% of stroke deaths, and 87% of stroke-related disability actually occurs in lower middle-income countries like Nigeria. We don't have good stroke registries in our country. We don't have good stroke registries in our region, but we do have some data that is not current, which tells me that likely things are worse than we are reporting. This data that I'm reporting is already a few years old. So in our area of the world, the strokes tend to happen within the 4th to 6th decade of life. And these have profound societal implications, as you can imagine. We're not a country that has nursing and rehab centers widely available. There is a huge challenge fiscally and economically with people affording care. So you can imagine the long-term implications financially of having to care for a person who has become completely dependent on family members to care for them. We don't have a safety net. We don't have a role of health insurance. We don't have good penetration of physical therapy and nursing homes. And so usually the burden of caring for people who are severely debilitated from stroke falls on their families. This was an alarming statistics. The annual incidence rate of stroke in Africa is 316 per 100,000 individuals. So for every 100,000 individuals you see, 316 of them are likely to experience a stroke in Africa. We have some of the highest incident rates of stroke in the world. Now think of the fact that Nigeria is the most populous country in Africa, and we're on target to be one of the most populous nations in the world. India, China, probably Nigeria is coming up soon. With 220 million Nigerians, and you're thinking about an incidence rate of 316 per 100,000, in absolute numbers, that is a lot of people who are at risk of stroke. In Nigeria, we have almost 1,400 per 100,000 reported in Nigeria. So we have some of the highest stroke incidence rates in the world, even higher than what is reported in Africa at 316. And unfortunately, most people don't survive strokes when they have them in our region. We have about 80% of people who have stroke ending up dying within 3 years. So this is an acute emergency, and it's something that we really need to think about in terms of how we are going to manage this in our nation. There's so many risk factors for this. High blood pressure, which is rampant. 1 in 4 Nigerians has hypertension. Smoking, diabetes, high cholesterol, another rampant risk factor, which is likely diet related. Many of us have high cholesterol. Obesity, sedentary lifestyles, family history, age, and then certain medications that we take can also put you at risk of stroke. So there are very many different kinds of stroke, and the treatment depends on the kind of stroke that you have. So if you have an ischemic stroke, there are different kinds of ischemic stroke. Thrombotic stroke happens when arteries to the brain, and that area of the brain stops getting oxygen because there's a lack of blood, and it leads to a stroke. And this is usually because there are fatty deposits building up in the blood vessels of the brain. You can also have something called an embolic stroke, where a blood clot breaks off and travels to another part of the brain or the neck, blocks a vessel distant from where it originated, and causes a stroke. And the last type of ischemic stroke is a small vessel disease stroke, which occurs when you have this progressive narrowing, blockage, or damage of small arteries within the brains. And eventually, there's enough damage to lead to a major stroke. On the other hand, we have hemorrhagic strokes. So in ischemic strokes, the blood doesn't get to the brain, there's a lack of oxygen, and that part of the brain undergoes infarction and dies. In a hemorrhagic stroke, a blood vessel ruptures and you're bleeding into your brain. And so you can have intracerebral hemorrhage. When this blood vessel ruptures or leaks, it causes bleeding. And because the brain is in the skull, which is a fixed space, you end up having a lot of pressure in the brain. And that is actually what is really concerning to us, because if the brain starts to go through the skull, through the small hole at the back of the brain, down into the spine, people will die. High blood pressure is a very common cause of this type of stroke, and we see a lot of hemorrhagic strokes in our practice environment. There's a second type of hemorrhagic stroke called a subarachnoid hemorrhage. There is space between the brain and a thin layer covering the brain, a thin fibrous layer. And sometimes blood vessels can weaken and then rupture into that space between the brain and the layer, causing this thing called the subarachnoid hemorrhage. One of the reasons why subarachnoid is very concerning is because sometimes it can be actually difficult to diagnose. And then diagnosing it actually involves some advanced modalities. You need to have CT scans in your facilities. You need to have a doctor who's capable of, and as we know, we have a massive exodus of specialists and doctors from Nigeria. So the other thing about strokes is that a lot of times the skills to diagnose are not available at many of our hospitals. So what do you do in a stroke? I'm going to keep things very simple. Of course, I'm an emergency doctor. So the first thing I'm going to say is that, please, once you recognize and see one of those signs I talked about, you really should get the person to a hospital right away. There are some medications we can give if the stroke follows certain criteria within 4.5 hours of symptom onset. Now, I have to tell everybody on the call that I have never, ever seen a stroke in Nigeria arrive within 4.5 hours. We are inevitably managing strokes a week, 48 hours, even 2 weeks after they happen. I've never been able to actually offer this therapy because I've never actually seen a stroke in Nigeria come within 4.5 hours of symptom onset for a variety of reasons. Once you get to hospital, in addition to everything we're doing, we're getting you oxygen, vitals, and monitoring your blood pressure and sugar, and really trying very speedily to get you into CAT scan to diagnose a stroke. If you're on any blood thinners, we're going to reverse that, especially if you're having a hemorrhagic stroke. And after that, of course, we're talking rehab and physical therapy long-term, hoping to replace and get back some of the function that might have been lost. So again, the best thing you can do for someone when you're concerned that they might be experiencing a stroke is to try to get them to a hospital as soon as possible, and preferably a hospital with a CT scan, because CT scan is required for diagnosing. If you go to a hospital that doesn't have one, inevitably, you'll need to get back in your car or in the ambulance and be referred somewhere where the stroke diagnosis can be made. The next thing I'd like to talk about is sepsis, which is something we see a lot in our environment. We have a lot of tropical infectious diseases, and we have a lot of neglected tropical infectious diseases in this environment that cause sepsis. In addition to us being the heartland of malaria, we're right squarely in the malaria belt, and we are really carrying the biggest global burden of malaria in the world, if you can believe it, Nigeria. Sepsis is a systemic inflammatory condition and is triggered by overwhelming infection. So sepsis is a different kind of beast. You can have a small pneumonia or a small urinary tract infection, but when you get septic, now it's overwhelming your system and causing rampant inflammation throughout the body. In our environment, the most common cause are bacterial infections, but we also see sepsis from viral infections and from fungal infections, and diabetics especially at higher risk of getting these infections and having them come in with an indolent cause that suddenly gets worse. Unfortunately, sepsis can lead to multi-organ failure, altered mental status, very dangerously low blood pressure, and if it's not treated quickly with volume resuscitation and IV antibiotics, people do die from sepsis. It kills 1 in 3 of those affected and results in an average ICU stay of 5 days and a mortality rate of almost 42% in patients. Now, again, think about this. I always like to bring it home. We're already in an environment where people are very poor. We're talking about multidimensional poverty in Nigeria. And the average is 0.5 million. So you can imagine the metrics of this, with sepsis killing 1 in 3 affected, with most of sepsis patients requiring an ICU, but the financial limitations of actually getting ICU care in our country. So it's really important to recognize sepsis quickly so that treatment can start quickly before it becomes multi-organ failure. Who's at risk of this? Extremes of age, so pediatrics, geriatrics, sepsis is worse. Weakened immune system, cancer patients on chemotherapy, HIV patients, or anybody who has some kind of congenital immune defect that makes their immune system not work well is more likely to get sepsis quicker. A chronic sickle cell anemia patients are also at risk of sepsis because their spleens don't work very well, and the spleen is one of the organs that helps to clean the blood. Also, hypertension, diabetes, and any of those chronic illnesses puts you at risk of sepsis. Invasive medical procedures, so after surgery, you've been opened up. If it's not done sterilely, we might as well just inject the infection directly into the sterile space. And then anybody who's had burns or wounds, our skin is actually our biggest organ, covering our entire body. And when we have burns or wounds to the skin, we've essentially opened up the barrier that's preventing us from interfacing with the environment in a bad way, and it puts us at risk for sepsis. So what do you do in this? There isn't very much that can be done for sepsis at home beyond, again, getting people to care very quickly. We need to start close monitoring. We need IV antibiotics. We need to really start our care quite soon. And we need to transfer patients to the hospital to provide critical care and administer IV antibiotics. So if you've got your person at home who's really having fevers, getting confused, has stopped urinating, maybe is having really big difficulty breathing, you really need to think about them becoming septic and make sure that you're getting them to hospital right away. The earlier care starts, the better the chance of survival. Let's go on to chest pain. It's commonly seen in the emergency. Again, hypertension is rampant in our environment, and hypertension is one of the major risk factors for chest pain. We can also see it coming in because of cardiac ischemia and heart attacks. A lot of our heart failure patients come in with chest pain. And then pulmonary embolus, which is a clot in the lung, can also cause chest pain. These patients need ECG, they need advanced imaging, they need to see specialists and be managed. And so it's really important, again, that we get them to hospital. The key diagnostic step in chest pain is to get an ECG. And so I would urge everybody on the call to make sure that if you ever experience this or have somebody experiencing it around you, you are taking them to a hospital that is capable of actually doing the diagnostic tests required to make a diagnosis about what might be the cause of the chest pain. Let's talk about seizures. Very commonly seen in our emergency department, especially in our kids. Infections like malaria that can become cerebral, affecting the brain, can cause seizures. Strokes can actually also cause seizures. And it's not as easy sometimes as it seems to differentiate between someone having a stroke and somebody having a stroke-related seizure. Electrolyte abnormalities. If you have low sodium or low potassium or calcium abnormalities, you might have a stroke. We see quite a number of seizures from people who've had head trauma and head injury. Brain tumors can cause seizures. People who are addicted to drugs, alcohol, who suddenly stop, can have seizures because they are dependent on those medicines. People with developmental disorders can also have seizures. Autistic patients who are having seizures Seizures, things that people take recreationally can lower the seizure threshold and make them predisposed to have seizures. Things like cocaine. You can also get seizures actually from sleep deprivation. So it's really important to make sure that we're all getting good rest. So what do you do in seizures? This is one of my favorite things to talk about because it's incredible to know how much misinformation exists around what to do with a seizure. First of all, if you're the observer, you need to stay calm. The most important thing you can do for someone seizing is to ensure that the area around the patient is safe. Push furniture that they might hit their head on away. Maybe put something like a pillow under their head so that they're not banging their heads on the floor. Maybe turn them on their side so that if they vomit, they don't swallow their vomit. You might want to time the seizure. When seizures are going on for longer than 5 minutes, you really need to start thinking about hospital. Certainly, you need to go to hospital if this is the first seizure or if patients are experiencing back-to-back seizures. That's an emergency. You want to protect the head as best as possible. Please don't put anything in people's mouths. I see so many WhatsApp messages about this. Please don't put spoons in their mouths. Don't put tongue depressors in their mouth. Don't put pieces of wood in their mouth. Don't put anything in the person's mouth when they're seizing. Don't restrain the patient. People try to hold them down. No, don't restrain a seizure patient because you might actually end up causing more harm to the patient. And you want to stay with the patient at least until they stop their seizure and hopefully get back to basics. That's all I've got so far regarding our emergency management of conditions that are commonly seen. At this point, I'm going to take some questions. These were my references for the talk in case anybody is interested to look at them.